Ann Bealke is a licensed mental health counselor. She has a BA in counseling from Marshall University, Huntington, West Virginia, and a MA in counseling, Columbia International University in Columbia, South Carolina. Among other skills, she is trained in accelerated resolution therapy for trauma treatment. Ann is also a U.S. Navy veteran with 14 years active duty as a supply chief. Her work experience includes work in several varied mental health settings: a domestic violence shelter, Army inpatient psychiatric unit, outpatient clinic for children and adolescents, private practices, overseas and domestic missionary locations, and church counseling centers. Ann believes that the relationship between a counselor and a client is a place where mutual respect, compassion, and safety create a place for learning, starting over, being accepted, and in growth. Along with Ann sharing the stage is Amy Schumann, who has more than 25 years professional experience working in clinical, administrative, research, academic, and group social work. She holds the credential Diplomate in Clinical Social Work through the NASW. She specializes in treating trauma, anxiety, abuse, and issues related to sexual orientation and gender. She is also a master therapist and lead trainer in accelerated resolution therapy since 2009. As a researcher and research assistant, Amy is a co-author of several study publications under the leadership of principal investigator Dr. Kevin Kipp. She is lead author in a pending textbook chapter for graduate studies in psychological counseling. Pretty decent credentials for both. Please welcome Ann Bealke and Amy Schumann.
Thank you, Jeff. Good morning, everybody. There was somebody here the other day who said something about, I am standing up, and I think that's definitely the message for me today. So I am Ann Bealke, and as you heard, I've had a little bit of experience in counseling here. Started my bachelor's degree back in 1994. I've been doing this stuff ever since. I absolutely love it, and it drives me crazy, but it's really, really good stuff. The one thing that I really love is to work with clients who allow an opportunity for learning and growth, and I see that comes to pass and comes to fruition. When we talk about periodic paralysis, how did I get connected with PPA? Well, Linda asked me to come and to talk today about PPA as a result of having clients who have PPA. I have a couple of clients on my caseload that have PP. And what happens with that with me is the clients that I see have struggled with several conditions that we've been able to help with. The ones that you see on the screen, not all of these at all times, obviously, but back and forth through what they go through, not only with episodes and trying to manage their condition, their physical condition, but also manage their mental health conditions. And there's clear evidence, we know that there is a mind-body connection there. When we activate the autonomic nervous system in a fight, flight, or freeze mode, there's definitely a physiological response. And the physiological response can exacerbate the mental response or the emotional, psychological response. And then these things will absolutely wreak havoc together. And so these issues can be effectively treated by licensed mental health counselors, social workers, psychologists, and so forth. And I would really encourage you to consider this part of your health care, this part of your life. The doctors that are here today, I want to thank you for the passionate approach that you take to this particular condition. I know that people here are very grateful, and certainly I am as well. And I know that it's difficult to just plow every day looking for answers and doing research. And we really appreciate the dedication that you have committed to this issue. In that, I would also like to say that as I present this information today, those of you who are physicians, I would ask that you would consider that when your clients and your patients are coming to see you, that perhaps check with them to see how they're doing outside of their physical condition. And if there's a referral that's necessary or that would be really convenient, prudent, and very fruitful, that you would make those referrals so that people could get assistance with some of these other issues. We've just heard a lot about anxiety. And we've talked a lot about anxiety. And when my clients that have PP are in my office, we work with anxiety a lot. And we also talk about trauma. And this is one of the things that Linda wanted me to talk about because it's very traumatic. Even the questions that you just asked and the responses you receive indicate to me that this is a harrowing situation repeatedly over time. And my heart is in that place where, as this is difficult for you, there is something that you can do in this type of support, not only to take care of your physical well-being in as much as you're able, but also to take care of this part of your life as well. So, as we see, the clinical definition of post-traumatic stress disorder is one of the things that I'm going to present today, so that if those symptoms are very familiar to you and it sounds like maybe you need to get checked out, then you can make a choice to do that. We're going to look at a criteria for clinical diagnosis of PTSD. We're also going to take look at 3 treatment options that are shown to be highly effective in treating trauma. Now, post-traumatic stress disorder is a psychiatric disorder that can occur in people who have experienced or witnessed a traumatic event, such as natural disaster, serious accident, terrorist or combat, rape, other violent personal assaults. This is a definition that's provided to us by the American Psychiatric Association. And where do we get that definition? Then what we see is this comes from the DSM-5, which is the Diagnostic and Statistical Manual, the 5th edition, developed by the American Psychiatric Association. And it's used by healthcare professionals in the U.S. and most other countries and to determine the mental diagnoses and in order to create treatment plans that are appropriate to the diagnoses. It provides a common vocabulary for professionals, and it establishes standards for mental health diagnoses. PTSD is categorized as trauma and stress related, and it's diagnosed if symptoms are present more than a month, diagnosed if symptoms of impairment or stress are present across areas of life, work, school, home, personal, social relationships and settings. The diagnosis or the dissociative reactions recurrent distressing trauma-related dreams, dissociative reactions, for example, flashbacks, reliving or versus remembering something, numbing out, feeling disconnected, feeling almost like an out-of-body type of experience, and that things are not real. Memory lapses or difficulty focusing are also common in PTSD. Intense and prolonged, longer than a month, distress after a traumatic exposure, and significant physical reactivity after exposure to trauma-related stimuli, for example, sweating, shaking, heart racing, and feeling smothery. And if you think about some of these symptoms that we're talking about here, many of them you have described on a physical plane today as a result of your conditions. And those of you who are caretakers, those of you that have seen your loved one go through these things, this can also apply to you as well. And so keep that in mind as we go along. Avoidance, at least one of the following 2 symptoms, persistent avoidance of thoughts and memories, for example, isolating, sleeping too much or too little, self-medicating, occupying time with TV, videos, video games, not engaging in things you used to enjoy like hobbies, travel, visiting with friends or family, social activities, volunteering, and so forth. Persistent avoidance is another one of external reminders. For example, a certain place you really don't want to go back to, colors, smells, sounds, activities, and situations. The negative changes in cognition and mood, thinking and feeling are another criteria, and of these, at least 2 of these symptoms have to be present for a clinical diagnosis. Dissociative amnesia of the traumatic event. I can't remember. I know that it happened. I know something happened, but I can't remember it or remember the details. Persistent negative expectations, overall sense of pessimism. I just don't feel like anything good is ever going to happen again. So persistent distorted blame of self or others about the traumatic events. I see many people with trauma have this as really a strong symptom with or without PTSD full diagnosis, where they really take on an inappropriate blame or guilt for having, for example, an episode, or they feel guilty about their loved one who's trying to take care of them, and this causes a lot of stress. So a persistent negative emotional state is another one, feeling down or angry, anxious. I talked with somebody earlier today who said, I can't tell you how anxious I've been. Another person said, I just stay angry, just agitated. I'm always on edge, and it's really hard to deal with. And if you think it's hard to deal with for me, you should talk to my family and my loved ones and the people who care for me. So diminished interest and participation in significant activities, feeling of being detached or estranged from others, persistent inability to experience positive emotions. So a last category here is alterations in arousal and reactivity. At least two of these have to be present for a clinical diagnosis of PTSD. Irritable behavior or angry outbursts. We just talked a little bit about that. Irritability. Reckless or defensive, self-destructive behavior. Hypervigilance. Extreme caution. Checking, and rechecking something. Exaggerated startle responses. If some slight noise just makes you jump out of your skin, this is an exaggerated startle response. Problems with concentration, focus. Sleep disturbance. Now, PTSD is a result of medical emergencies. After I started treating someone with PP, I began to wonder about this and what the incident is of trauma, actually a trauma diagnosis with like PTSD. What happens with medical conditions like PP? Obviously, very little, if any, research out there on this, and what I did find was certainly not about PP, but it was about other things. And the studies that I reviewed specifically were based on specific medical procedures or hospital stays. For example, PTSD was diagnosed after heart attacks, medical interventions, surgical or diagnostic procedures. And all the studies I reviewed showed significant numbers of diagnoses of PTSD after traumatic medical intervention in an average of 25 to 30% of the people that had these experiences. So depending on the type of intervention, these percentages increase proportionately with the intensity of the situation as it's perceived by the person who is fearing life or death. So PTSD and periodic paralysis. So those 5 symptom clusters, here are some things I've seen in my clients. Exposure to traumatizing events, either a PP episode itself or medical intervention when someone has to be let's say, transported in an ambulance. One of the first things they want to do, EMTs are trained most often to start an IV. So what's in an IV? Ringer's lactate and normal saline. Usually those things are not great with PP. Is that right? This is what I'm noticing and learning from you and from the doctors. Intrusive symptoms, thoughts, dreams, flashbacks of either episodes or the medical interventions that they've experienced. Avoidance, avoiding places, sounds, sights, and smells that remind you of the trauma. I talked with one person who said they didn't come to this conference because their anxiety was so high that they had a panic attack. I think that's a significant avoidance that's directly related to what she had gone through in some other situations, and that was medical treatment. And she knew that everybody that was here was going to be talking about the medical aspect and the pharmacological aspects of this condition. So her anxiety was extremely high. So there are negative changes in thinking and mood, like depression, anxiety, irritability, anger, difficulty focusing, change in arousal and reactivity, easily started, jumpy, inordinate fears, and excessive worry. And I want you to remember, I'll go back to this slide just one moment. I want you to remember that those of you who are in this room who are caring for a loved one, a friend, a relative who has PP, all of these symptoms and categories of symptoms can also lead to trauma for you as well, even if you've never had an episode. Many of you are related to the person that you're here with or other family members that you have here, and I realize that many of you in the same family have PP, and so I see both the individual and I also see family members at times when that's appropriate. Evidence-based treatment options for PTSD. One of the top and probably gold standard treatment protocols for PTSD has been EMDR, which is eye movement desensitization and reprocessing. It was started in 1987. Historically, this has been VA's really go-to preferred treatment for combat PTSD. Believed to be that it is effective through the use of eye movements that stimulate, or rather that simulate, REM sleep. And when you think about REM sleep, we're talking about a sleep mode that is relaxed and the mind is as open and working and active at the same time as being relaxed. And so this is used in EMDR to reprocess traumatic experiences when all of that anger, all of that anxiety and other symptoms are coming up. An average is 10 to 12 sessions with EMDR to address trauma symptoms and manage them. The next one is cognitive processing. This has been a protocol that's been recognized in the mental health field since 1989, a couple of years after EMDR. It's a form of cognitive behavioral therapy in which focuses on changing the way clients think and behave in order to change the way they feel and react or interact. And it's based on the concept that symptoms are caused by the way a client thinks about the trauma. And in this one, the average is 12 sessions for adequate treatment. One of the new protocols that's out here is a new treatment for PTSD. When we say new, it's been used since 2008, accelerated resolution therapy. And the this one in particular uses several treatment approaches that are combined, including the rapid eye movement. And it changes the way stress-inducing memories are stored in the brain and thereby reduces or eliminates the negative physical and emotional effects of the trauma response. 1 to 3 sessions. This is what intrigued me so much about this particular approach to trauma. As a therapist, I would see clients coming to my office, and often they would be traumatized somewhere in their past. And when we were trying to work on their current life, those things would be activated, triggered, we say. And their response in some of these symptoms that we're talking about today would be vivid and visceral in the moment. And we would have to stop and deal with that and then come back to whatever we were dealing with in terms of therapy in the moment. So this would be a very long process at that time. But with one session, I've seen amazing, absolutely amazing results. I had a gentleman who was 72 years old. He was a Vietnam combat vet. He went to Vietnam when he was 19 years old. He was a combat medic in a field hospital, and he stayed there 2 years. I cannot imagine what that man suffered through in those 2 years, but I really can't imagine what he's suffered through ever since. He's been to a number of different types of treatment, pharmacological treatment as well. And his brother-in-law told him about me. He came to me, we sat down and talked through why he wanted the treatment, what he wanted to gain from the treatment, and we sat and actually went through this protocol together. With one session of him thinking about, only thinking about, not even talking about what happened to him, and going through a verbal protocol with him in which I would direct him what to do next and next and next. One session, within an hour and a half, this gentleman went home, came back the following week, and he said, "Ann, I don't know how that worked, but I've had the best 3 nights of sleep that I've had since I was a 19-year-old boy and went to Vietnam." His wife said, "I don't understand it either." This man is angry most of the time or extremely irritable, and that's gone. And I can only say to you, this works the same way for any trauma, and I've seen it over and over and over again in my office. Accelerated resolution therapy is really straightforward. It uses these eye movements, and those are very soothing, actually. And it's a technique that allows clients to change the way in which the negative images are stored in the brain. It moves traumatic memories from short-term memory to long-term past memories, and it works in part by using those rapid eye movements. The end result is that the trauma and the difficult life experiences that result from it will no longer trigger those strong emotions and those physical reactions. Importantly, though, we got to say clients do not even have to talk about what happened to them. It is not necessary. So this is really an exciting development in trauma treatment and resolution. What is ART not? It's not hypnotherapy. Nobody is hypnotized in my office. It does not create amnesia. You will remember what happened. You just won't have the same reactions that you had in the trauma responses. It does not change a person's personality. It does not replace counseling for relational challenges or for healing or changing an organic or physical condition in the brain, and I would also say certainly in the body, in the rest of the body. ART is not suitable for those who have active suicidal or homicidal ideation. Though once a person is stabilized with those thoughts, then they can consider ART. If you consider ART treatment for the trauma that you've been through, if that is you, I would highly recommend, if you're on medication, to talk to your doctors before you adjust or change or discontinue any kind of medication. I've had clients say, if I have an ART session or 2 or 3 and my trauma symptoms are gone, should I go off my medication? First off, I'm not a physician, and I cannot advise someone to change their medication in any way. But I can certainly admonish that person, please, whatever you do, don't change your medication without talking to your doctor. You and your doctor decide that together. If that's to be changed, make sure that it's changed in a safe way. Psychotropic medications in particular can bring about homicidal or suicidal ideation if they are abruptly discontinued, or they can exacerbate the very conditions that they're designed to treat and to help to relieve or manage. This treatment, ART, can be used to treat several types of mental health conditions, not just trauma. It can be used for anxiety, panic, depression, addiction, a long, long, long list now that we are seeing more and more in anecdotal research, and also the VA now has a 3-year study at the Cincinnati Department of Veterans Affairs Medical Hospital there, that they are examining ART head-to-head against other types of treatment protocols for trauma, and we will know more and more about this particular approach as time goes on. Amy is also going to talk with us this morning briefly about research in ART. Whatever type of treatment you decide to consider, physical or mental, I highly encourage you to do your own research. I see and hear what all of you are doing to try to understand your physical condition and many conditions, and I'm absolutely impressed, just thrilled to death that this is what you do. And I know that it's come out of necessity and desperation at times, but it is absolutely your body, and it is up to you what you do with it. I have a couple of websites. I will email those over to Linda, and she will have those to shotgun out an email to you, and some other resources that I'll have available for you as well. This is Amy Schumann that was introduced to you earlier. Let Amy talk to you about research. Amy, thank you.
So as Ann said, I'm here just to fill in a little bit about the research to give a little more credibility to accelerated resolution therapy, which is a therapy that's different from what people usually imagine or participate in when they're engaged in therapy. I'll just quickly say one part that we would spend a lot more time on if we had more time. There's another piece of what we now know about the brain that we utilize when we do accelerated resolution therapy. Okay. So I'm just going to quickly mention this to you, and if you jot it down and you're interested in learning more about memory, emotionally based memory in the brain, you may want to research. As a matter of fact, there's a PBS Nova special called Memory Hackers, which you can get on YouTube for free. And it's absolutely fascinating, telling you so much about how memory works in the brain. But there's a specific phenomenon that we capitalize on when we do accelerated resolution therapy. It's called memory reconsolidation. And in one sentence, I'll just say to you, whenever anybody recalls an emotionally based memory, when they bring up all the different parts of the brain together to recall all of the different senses and aspects of that memory becomes malleable. I use a metaphor and I tell people, think of it as the cement gets wet, and think about how you could put your hand in that cement and make an impression. While we use the eye movements, we take advantage of memory reconsolidation. When the window opens, it begins when the person first recalls the memory, and it lasts for 6 hours. So we have wet cement in that memory for 6 hours, and during that time, we're inviting the client to imagine any visualizations that would feel better to them, to implant as the director of the movie of the memory. So first we have them go through with the eye movements and watch the movie of the memory that illustrates the problem that they're working on. And finally we tell them to do a director's cut. As Ann said, we're not brainwashing or hypnotizing. The person could still tell you all of the facts about that memory after they engage in art, as we call it. But the images that comes up in their mind's eye as they talk about that situation will be the new images that they've put into that wet cement when they go through that session of art. And when they remember it a day later, 2 days later, one of my kids was the first person I tried this with when I was trained, which you're not supposed to do. But she told me she had a memory of a friend betraying her. So in November of 2009, when I started to do art, I had her do art with this memory of her friend betraying her. So that was, 11, I'm not good at math, 11 years ago, when I ask her still to this day, when you think about that memory, how do you see it? She still sees the new images that she put in. It was in a coffee shop, and she added golden light filling the room. She added her favorite song playing, and they were sharing a carrot cake cupcake, and she added making the carrot cake really big. She loved carrot cake. So those all brought up the affective states that go along with those new images. So while she could tell you the facts of the actual memory, she would be enjoying these new images that she put into the wet cement during that session, and it stuck 10 years later. So now I'm going to acknowledge Dr. Colonel Charles Hogue. If it wasn't for him, then we wouldn't be here talking to you about art. In about 2012, he read an article that was published in Military Medicine. As an Army colonel, he had access to that and read it religiously, and he saw the article that Dr. Kevin Kipp had published in the article about art. He was so intrigued by what he read because he's the person in military that is the foremost expert in treating military trauma, so much so that he's the most cited person in the world when it has to do with military trauma. And he wrote a book called Once a Warrior, Always a Warrior. And by the way, you're going to hear us talk a lot about military, but please don't think that that means that this therapy is just for military. It just so happens that the windows and doors that opened for us and the money for research that came about was because, as we know, so many people in the military are suffering from PTSD. But this is easily generalized to all of our population. So Charles Hogue wrote an article specifically about 5 components that must be in place in order for therapy to be considered to be credible for treating PTSD, and art meets all of those criteria. This is Dr. Kevin Kipp, and now I'm just going to bring you through a few slides to give you the research and the highlights of the research that's been done so far. Since this is a newer therapy and because it's so hard to get money for research, we go along the best we can, and there's been one major study with a randomized control trial. And the second study that Ann mentioned that's happening at the University of Cincinnati is past the halfway point in this 3-year study that compares ART to a tried and true certified therapy for military trauma called CPT, Cognitive Processing Therapy. Dr. Kate Shard, who is one of the founders of CPT, is running the study with her veterans up there against ART. So it's going to be so interesting to see how ART fares against this tried and true therapy. I just put this up if you want to take a picture of it. I'm going to put it up at the end too. Here's a lot of the articles that have been written about ART. But as you may know, if you're into research, if you just go to Google Scholar, if you put the keywords in accelerated resolution therapy, PTSD, then you'll find all of the articles, and they're all downloadable right from Google Scholar. Okay, I also want to mention that even though there aren't a lot of studies conducted so far, Kevin Kipp's studies were done so well that the National Registry of Evidence-Based Programs and Practices did certify ART in 2015 as evidence-based. Some of you may know, and many of you probably don't know, that this particular program at the federal level no longer exists. In January, it was abolished, and there's a different way that the government is going through giving information about how to find a credible therapy. But still, I think it's important to know that in 2015, when the program did exist, accelerated resolution therapy was determined to be evidence-based. The green check marks tell you what was found to be certified as evidence-based, and the yellow check marks tell you what looked promising, but more study is needed to bring it up to the level of the green check marks. Okay, here comes the fun part. So here's the sample for that big study that I told you about with the randomized control trial, and the control group was an attention control group. We had 57 people enrolled in the study. 29 were randomly assigned right away to the ART regimen. In the control condition, 28 were assigned to the intention control regimen. That is, they were offered 2 sessions of interaction with either LA fitness counselor or a career counselor, where they could set goals for either career or fitness. We thought this would be desirable to the veteran and active duty members that comprise these 57 people. The mean age, you can see, is about 40, mostly male. And the top red arrow shows you that about 40% were on military or veteran disability for PTSD or other mental health problems. So this tells you that these people who came in for the study, 40% of them were earning their living, perhaps supporting their family with disability money, and yet they were so uncomfortable with their PTSD, they were willing to try to get better and maybe risk losing that form of income. Of course, if they do get better, then they're going to be able to get a job, which is what we hope and want. But if you can see how that would be very scary for someone who's relying on that income. And yet we see 40% who came into the study did so while they were on the disability. And the second arrow points to the fact that most of these people had what we would call unretractable PTSD. It's not someone who just had one episode and that was bothering them. They probably had many years of compounded problems and not just PTSD that I'll show you in the next slide or so. But they definitely were suffering from PTSD for quite some time and tried other therapies before they finally came to this trial of ART. If you look at the bottom row going across, you'll see that 93% of the participants met the criteria for PTSD. I'm going to be talking about in these slides forward a questionnaire called the PCLM. That stands for the PTSD Checklist for Military. There exists a PCLM for military and a PCLC for civilians. And also because this study is a few years old, the PCLC and M, what it does is it asks questions that go right along with those criteria that Ann showed you, but from the previous DSM, the DSM-4. And when the person answers those questions, that's how it's determined whether or not they seem to meet the level where they may be diagnosed with PTSD. So it's not a diagnostic tool per se, but it's an indication that the person is aligning with the criteria that Anne showed you. Let's look at the main results. Each vertical line represents a veteran or service member in the study and their response on the PTS checklist. That lower horizontal line represents a 10-point reduction, which has been suggested to be the metric to indicate statistically and clinically meaningful change. So at that 10-point lower line, you can see whoever met that bar is highlighted in green here. You'll notice on the left in the ART group, the overwhelming majority had a drop at or below the 10-point cutoff. And notice on the right, in the control group, a couple had a 10-point drop and a few went in the wrong direction, which you can see going up in red. And when you look at the comparative means between the two groups, you see 17.2 drop in ART compared to 2 points in the control group. This is a very substantial difference, very highly significant. Okay, so this is the only other very busy slide, I think, that I'll be showing you. But you can see here, if you look down on the left, the comorbidities that show the same pattern held true. Those who were treated with ART showed a much better response on the comorbidities for depression, for anxiety, and for sleep. One surprising result had to do with the pain that the veterans had. A lot of them had combat experience, and on a 0 to 10 scale, 4 was considered to be the cutoff for significant or meaningful pain. And as you see here, about half of the veterans had reported having that level of pain. If you can see above each bar, a number of who fell into that score point. So you see under number 4, the red, where there was one person, et cetera. So all of the red indicate the people who were at 4 or above on the pain scale. And rather remarkably, this was not a hypothesis in the trial, but when the data was analyzed between the two groups, the drop in pain for the ART participants was substantial in self-reported pain reduction and a mixed bag in the control group. The mean changes were also striking, 17 points in the ART group and 0.7 in the control group. This was an unexpected finding, and we published this in the European Journal of Psychotraumatology. Kevin's an epidemiologist, and he loves to pool data. So I'm not telling you about the second study here. We just don't have enough time. But he pulled the data from the studies. And this slide compares the data between civilians and military people. And it also shows sexual trauma, which was among females. Here's a way to look at how each group started on their PCL score and where they were right after doing ART, and then a 3-month follow-up. You can see that the patterns were all similar, and you can see that the most notable outliers, that second cluster of 3, those are the military females. There were 9 of them, and they had the highest starting point with a mean PCL score of about 60. Remember, the cutoff is 44, so that's well above the cutoff to indicate PTSD. And they had a high prevalence of military sexual trauma, which is quite a big problem in the military. This was also published in Military Medicine. A closer look at the sexual trauma as the source of primary trauma. Remember, green is good, at least a 10-point drop in the PCL score. Civilians had a 22-point drop, and military females had an average of a 21-point drop. So it appears that ART is a very good treatment for sexual trauma. Because of the surprising results on pain, Kevin decided to look at neuropathic pain. In the group that he had, he looked at pain related to diabetes, chemotherapy, and pain that was of an idiopathic nature. He recruited 10 adults, so this is a pilot study, And he measured before, after, and 1 month follow-up. You can see the suggestion of the trends pre and post-ART. On the scale on the left side, that reflects the level of pain. So you see clearly the level of pain is going down. The scale on the right side reports quality of life. So you can see clearly that that scale is going up. Finally, I'll just mention that lately Kevin has been very interested in doing EEG studies. And here you see a little case series with 9 veterans who have PTSD against 9 control subjects that do not have PTSD. So what they did is they took a nap before they had ART, and they had their EEG done, then they had ART, and then they had another nap and another EEG afterwards. The control group just had 1 EEG with a nap. And here were the results. In red, you see what the EEG, when they showed the level of discomfort that by virtue of the brain waves, in red, pre-ART. In green was the nap after ART, so clearly you see a trend going down, not down as low as the blue dots, which indicate the people who didn't have PTSD, but clearly in the good direction. So right now, I know he's gotten a much fancier monitor that he can put on someone's head that's less intrusive than all those wires that have to be put on. And so currently, I know that he's conducting another study using EEG. So this is, again, the list of articles that if you'd like to take a picture, or you can find easily on Google Scholar. And that concludes my talk.
To finish up today, we have a really, really short video. It's about 3 or 4 minutes, and it kind of illustrates a little bit of what we're talking about. And we'll be available a little bit later for questions and answers. Amy and I have a table set up down against this wall back here, and we're almost done.
Ready? 3, 2, 1, action. 125 decibels right there. We're gonna have to clean this up. Where do you want me to stand? I just like walk up, introduce yourself maybe more times. Okay. That's like, cool. And then when they look around, you guys are completely normal, like nothing happened.
Hey, good morning.
Hey, how are you?
Good, how are you?
Good, good, good.
Can I have a hot chocolate?
So you just want, do you want a double espresso or a single?
Double is fine.
Okay.
You got whole milk?
I do.
Let's do it.
Okay, do you want a medium, large?
No, medium.
Medium, and do you want that for here?
Yes, please.
All right. Let's get this going for you. Do you want that for here or to go?
For here is fine.
Okay.
All right, get ready. 3, 2.
Okay.
Did you hear that?
Hear what?
That explosion.
No. Just making some coffee. What's the weather like outside today?
Freezing.
Is it? Yeah, I'm not a big fan of the cold. That's why I live here.
He's gonna shake you. Get ready for dog barks.
I don't know why I do it, but sometimes I just have to shake the beans, too. There you go. Thank you very much. What was that? What was what? You guys enjoy the day?
Thank you.
Let's get out of here.
I don't know.
Pat, Hey, guys. Come on over here. We've got cameras right here, and we've got a camera right here, a camera back here, a camera right here, one right back here, one right up there. And if you don't mind, I'm going to take you in the back here. Just go on through.
Thank you.
Oh, you okay? What happened there? I'm veering you onto the one coffee I know how to make with my 4 hours of training as a barista. So, did you notice at all that no one else is reacting to the noise?
Uh-huh.
How'd that kind of make you feel?
Alone?
I just wanted somebody else to be on the same wavelength as me, because I felt like I was the outcast and nothing happened. Nobody looked around, nobody looked at me, and nothing.
How'd that make you feel?
Isolated?
What would you think if you had to deal with the same things you dealt with today, every day?
That would be debilitating. It would be scary to even leave my house because you don't know when or what to expect from day-to-day life.
That's what 24 million U.S. citizens deal with on a daily basis. It's not mostly veterans.
Really?
A lot of people go through a lot of difficulties with post-traumatic stress. Did you hear the dog bark? Did you hear the car wreck?
I did, yeah.
I was a Green Beret. I lost 5 friends in a 6-month period. You know, it's hard. It's just a memory or emotional attachment to something that you need to work through.
It's jarring. And not just my personal, but to hear the numbers and to hear your story a little bit and know that people are suffering in silence. It's always been the sort of thing where you don't really talk about it, and that's not right, you know, if we're gonna heal, you know?
Chris, come here, brother. Get another hug from you. Thanks, man.
Thank you.
Yeah, I really do.
Right on, man. Yeah, nice to meet you.
Nice to meet you as well.
Yeah.
Thank you for doing this.
Of course.
Thank you.
So if you have any trauma symptoms at all, with or without a diagnosis, my compassion is with you and for you. You may never have been in combat and you may never go to combat, but in several ways you live combat on a daily basis. What I've heard in this conference Friday, Saturday, and again today, that many of you fight the fight and manage your symptoms as best you can, manage emergencies and crises as best you can, and a doctor, your physician, may never see this other side of you, may never see what your family members are going through, may never see at 2 a.m. when that overwhelming sense of anxiety or that dark depression comes, or these startle reflexes, or so many of the other things that we talked about today. I want to encourage you, if this is you, if you experience these things, to support your physical health, I would encourage you to consider seriously your mental health, your emotional health. I would encourage you to find someone who can do that. You can look for people who specialize in trauma treatment, anxiety treatment, depression, and so forth. We're going to send Linda also a link that will have a place where you can search for ART therapists on there. If there aren't any in your area, then this phone number is a phone number you can call and talk to them about maybe coming to your area and training therapists to help you. So I appreciate you very much. Appreciate your patience today. Thank you so much.
Does anybody have any questions for Ann or Amy?
So you said that a possible symptom can be a loss of memory. If someone doesn't remember something, or if they remember it wrong, which you didn't mention, but can that be something that can be fixed by this, or will that stay the same but just not be so traumatic?
The latter.
Okay.
When somebody sits with me and I do an ART session, and Amy alluded to the eye movement, and we direct that with our hand when we're going through the session, what we do is we challenge that brain in the way that that memory is stored. It's stored together with both the memory of what actually happened and also all of the feelings that went with that, and then the triggers come out of those intrusive thoughts and memories from that. So we challenge that brain to separate those responses. And as we start working with somebody, we see that autonomic nervous system kick in. When I start working with somebody and they start remembering what happened, they don't have to say what happened. But as soon as they start remembering it, whatever their coping strategy is for their body, that brain sends those signals, and that happens. Increased heart rate, increased respiration, tightness in muscles and body. And as those things are coming, we immediately go to work on separating that from the memory. And it's very, very effective. I wanted to also add one thing. One of my clients has a difficulty with vertigo. And talking with the woman who designed this particular approach, what she suggested is, as we do the eye movements, that she should close her eyes and do them more slowly, and that we could proceed through the session as she needed, just timing it in a way that would be effective for her, that wouldn't be overwhelming. And we just took extra time. I scheduled extra time that day, and we just took all the time she needed. So I hope that's helpful.
My daughter is going through Emdr therapy right now with a therapist, and
wonderful.
And the therapist actually uses a hand stimulator instead of the eye movement. Is that just as effective, or what is your experience in that?
I'm not familiar with the research on the comparison between the two approaches. With EMDR, I'm not a trained or certified EMDR therapist, but I love the question, and for me, I would be just as intrigued, and I would want to know that difference. The one thing that we do know is that the reports that you've seen, if somebody had already had EMDR and was still struggling, if they go then and have ART sessions, what they're looking at is usually a reduction that's drastic in those symptoms, or an eradication, an elimination of those trauma symptoms. It's pretty phenomenal. Amy, you had something?
And I want to just add to what Ann said. We really prefer to use the eye movements, so closing the eyes, if that could work, would really be ideal, but not because of what research tells us necessarily, although research does show us that the smooth pursuit eye movements are correlated with relaxation. I got to get in the hot light. So the eye movements have been shown smooth pursuit, so if you're watching a tennis game, back and forth, they're correlated with a relaxation response in the brain. So we do prefer eye movements, but if it's determined that absolutely a person cannot do it with the eyes open, they cannot do it with the eyes closed, we can do other forms of bilateral stimulation. Like I think for the EMDR, you were talking about the wands that the person holds in both hands and a pulse beats from one hand to the other, or tapping from shoulder to shoulder, or have the person themselves tapping back and forth. So we would go to attempting bilateral stimulation without the eye movements. We can experiment and find some way that the person can tolerate and have that bilateral experience while we go through the protocol.
Thank you. Thank you, Amy.
Yeah?
Go ahead.
Okay. I had EMDR therapy many years ago, 6, 7 years ago.
Yes.
I had surgery in 1991, and I was in a full body paralysis. Anesthesia didn't work, and I showed only one tear here every time, but they didn't see it. And I felt the cutting and the drilling, that kind of things. But I'm okay with that now. I had, I had surgery after.
Yes.
It gives me okay feeling.
Yes, yes.
And I needed that second
it's very
and third
helpful.
surgery.
Yes,
and,
absolutely.
It didn't work only the months I visit the therapist, but even now it's still progressing.
It
Is
continues.
that a good word?
Yes.
Yeah?
Yes.
Okay.
Yes, very good.
I'm much stronger even.
Yes, and I really love what you're saying, because once we gain some traction with something that really bothers us, hurts us, and keeps us down, once we get some forward momentum in that, that is so encouraging, and it gives us such confidence to just push, push, push to get better and better and better. And I love that you got relief. That's absolutely wonderful. It's beautiful. Thank you for saying that.
Hello.
Hello.
I'm not afraid to say it, but Ann is my counselor, and I have had ART, so if anybody has any questions from a personal experience of doing ART, I'd be happy to answer them. And I did it, and we're going to do more working on like the medical trauma of emergency rooms. I could probably ask you to raise your hand on who has medical trauma in an emergency room, and we'd probably get 100% response. So anyway, that's one of our goals eventually.
Yes.
So thanks for being here and for your information.
Thank you, Christine. Thank you so much. One last note, those of you that are here today, if you take a look at this list that we talked about earlier, if you feel comfortable in doing so, if you have experienced significant struggles, and I'm not talking about completely debilitating, but just some pretty serious struggles with any of these conditions, will you raise your hand? Anyone with any of these conditions? Those of you who are physicians, will you look around and see that this is the case with some of your patients? And if they are encouraged to and supported in getting mental health care, that would go a long way in addressing some of these issues. That would also very much stand to support what they're going through with PP. So once again, I thank you, and I'll send that directory link out to Linda and get that to you. Anyone else?
I think one of the big challenges as a physician, we always dump the mental health on the primary care docs. The primary care doc has to screen for depression, screen for all these other issues. And then when they go to a specialist, like if someone comes in to dermatology and they have, bad skin disease, I know they have psychic trauma from their skin disease, and they for the last 20 years they're walking around, embarrassed about it, and plus. But I'm so busy taking care of the skin disease that I don't have time to start exploring the psychological. And then if we do go there, and I say, okay, well, you should see a psychiatrist, or well, they either can't afford a psychotherapist or a psychologist, or their insurance doesn't cover a psychiatrist. So what do you do if they need it and there's no access?
That's a great question. One of the things that I encourage people throughout our community, and I practice here in Central Florida, one of the things that I encourage is that you call around and talk to some therapists and talk to them about a sliding scale fee. Some people do pro bono work as well. A portion of their practice is dedicated to pro bono work, and that is that therapist giving back, and they will take X number of clients on their caseload for free. So I would definitely ask about pro bono work. I would also then come back and ask about sliding scale fee. My rates are probably right at 50% of what the going Central Florida rates are. I try to keep my rates low. I have low overhead because I'm provided a free office, which helps, but do ask. And those of you who don't have access immediately to mental health care, some of the things that we're talking about You may be able to access through video sessions as well. Those are available pretty readily now and growing fast. That's one of the fastest mental health care advances in our system.
Also, it's a good time for me to remember and to mention to you that the people who sponsored the table and flew me out here to join in at Art International are being sponsored by a philanthropic wealthy man, Chris Sullivan, who gained his wealth initially by being a co-owner of Outback Steakhouse, and since then he owns many chains of restaurants. There's one out here called Carrabba's. There's several others that he owns. So because he's so wealthy, he has a passion for treating PTSD, and originally for treating PTSD in veterans, but that's branched out to everybody. He has a couple of opportunities for people. So anybody who's a veteran and who's suffering from PTSD, he has in Holiday, Florida, a retreat for any veteran for free. He'll fly them there from anywhere in the country, and they'll spend a week. They'll get art, and they'll get yoga, and they'll get some other things. And also, if you call them, they have some other organizations that pay for therapy. There's one called Rebecca's Angels that's paying for a woman who's got trauma who's seeing me in Massachusetts. So if you call them, they might have some ideas of where you can find funding for therapy.
Oh, thanks. And I actually think we found a new condition, PTSD. There we go. Got a new, okay, so we got one more.
We got one more here from Aaron.
All right.
Aaron wants to make a comment.
Before I found a therapist, they sent me to the police, to the military doctors, and they refused to help me because I had paralysis. So maybe it's hard to find a good therapist who's willing to help in the hospital.
Yes, a very good point, thank you. And I would say if you hit a roadblock or a stumbling block, don't stop. Don't stop looking, because there are more of us out there. If you don't get a yes from one, call another. And if they can't see you or won't see you, to me the magic question is, who do you refer to in my situation? Who in practice are you referring clients to? And I would just keep calling, keep doing that research until you find somebody. And again, if you look for somebody who sees people with chronic medical conditions, you will most likely find someone who's doing this kind of work.
Great. So it is like 10:50-ish. The remainder of the conference would be, I think, just kind of open question and answer. If you have any stories to share or questions about your own medical condition that maybe might be applicable to everyone else. But I feel like we should take a break for like 10 minutes, and then whoever comes back, and we'll hang out for 10, 15 minutes, but maybe we'll end a little early. So thank you guys.